Assalamu alaikum wa rahmatullah. My name is Ahmed Emad Ali. I'm a fifth year medical student at Sulaiman Rashi Colleges. I'm inshallah be presenting to you the pregnancy complications part 2. هذه learning objective إن شاء الله تكون سهلة عليكم ومش معقدة. Let's start by the first question. 37 years old woman, Gravida 3, Para 2, at the 28 weeks gestation, comes to the physician for follow-up examination. 1 week ago, an oral glucose tolerance screening test showed elevated serum glucose levels. She's complied with the recommended diet and lifestyle modifications. Over the past week, home glucose monitoring home blood glucose monitoring showed elevated fasting and postprandial blood glucose levels. Which of the following is the best management? Insulin, metformin, GPP4 inhibitors, glyburide. So from the question stem, we understand that the question يعني الموضوع بيدور حول الجستيشنال diabetes. Let's first define what is gestational diabetes. It is glucose intolerance that starts in pregnancy and lasts until the 6th week postpartum. From the start of pregnancy till the 6th week postpartum. I will talk about the complications and manifestations of gestational diabetes. But first, let's talk about the screening of gestational diabetes. The screening is recommended between weeks 24 and 28 of pregnancy. And actually, the initial screening is by the following. 50 gram oral glucose. And 1 hour after that, we will measure the blood glucose level. A positive test will be a blood glucose of more than 140 milligram per deciliter. I know it is a bit complicated, but one important point I want to add here is that it is a screening test. Now we all know that each in order to confirm a diagnosis, we can't rely on a screening test. We have to do a confirmatory test for a positive screening test. So the confirmatory test it is also called 3-hour oral glucose tolerance test. It involves 4 steps. The pregnant lady has to be fasting, and we give her 100 gram of glucose drink. She will drink that, and after we will measure the blood glucose in the first and the second and the third hour. A positive test is will be the woman will have 2 or more of the following. Now for the management, there is non-medical therapy and the medical therapy. دائما بنبدأ في أمراض السكر بالnon-medical therapy. The first line is dietary modifications, always with regular exercises like walking and with measurement of blood glucose daily, at least 3 to 4 times. And if the dietary modifications didn't work, we have to add a medical therapy. And the first line here in the medical therapy is the insulin. If the woman refuses the insulin therapy, it's okay. We can give her metformin and glyburide. It's not contraindicated in pregnancy, as well as they are not teratogenic. And also, we must not forget about the fetus. We have to regularly evaluate the fetal development by ultrasound, as we are going to see the complications of gestational diabetes. And also consider inducing delivery at the week 39 to 40 if glycemic control is poor or if complication occurs. And important note here, all women should be screened again for diabetes after 6 to 12 week postpartum. Now, what do you think the answer? What's the best management? Insulin, metformin, GPP4 inhibitors, or glyburide? You can write in the chat why you choose your answer. That's correct. Insulin is the correct answer. And the reason is that she tried the diet and lifestyle modifications, but also it didn't work. So we are going to step up to the medical therapy, which is the insulin, is the first line, unless the patient refuses. Okay, perfect. For the second question, a 25-year-old woman at 12-week gestation comes to the office for a prenatal visit. She had history of type 1 diabetes mellitus. Her vital signs are within normal limits. Laboratory studies showed a fasting blood glucose of 160. Which of the following complications is most likely to happen to the fetus? Polyhydramnios, preeclampsia, congenital malformations, and respiratory distress syndrome. Now for the complications of gestational diabetes. I separated the fetal complications for the maternal complications for the sake of simplicity عشان أسهلها عليكم لما تيجي تراجعوا البرزنتيشن إن شاء الله. The most important fetal complication is that congenital malformations, and it happens especially in the first trimester. أنا دايما بطلق على الفيرست trimester الكريتيكال trimester where the organogenesis all take place in this trimester. So just any like any pathology to the mother can affect the fetus markedly in this period. As well as preterm delivery, polyhydramnios, altered fetal growth, respiratory distress syndrome, and neonatal hypoglycemia and inheritance of diabetes. For the maternal effects, gestational diabetes increases the risk for the mother to develop hypertension disorders. And they are also at risk of the development of type 2 diabetes in the future, as well as obesity and recurrent gestational diabetes in the next pregnancies. By means of, if the mother have gestational diabetes in this pregnancy, she is at high risk to develop gestational diabetes again in the next pregnancies, as well as infections. And most common ones includes candida, vulvovaginitis, and UTIs. So which of the following complications is most likely to happen to the fetus? Well, that's correct. Congenital malformations. Perfect. And why congenital malformations? You can write in the chat. I think the first sentence of the question is the answer. The answer is hidden there because she is in the correct, the first trimester. Question number 3. A 36 years old woman pregnant comes to the physician for a prenatal visit at 15 weeks gestation. She has had episodic headache over the past month. Her blood pressure is 180/110 mmHg. Urine analysis shows no abnormalities. Which of the following is most likely diagnosis? Preeclampsia, gestational hypertension, essential hypertension, and eclampsia. طيب أنا عايز أبسط موضوع الهايبرتنشن in pregnancy بطريقة يعني تفتكروها وقت ما أنتوا عايزين في اختبار أو حد سألكم أو زي كده. For essential hypertension or chronic hypertension, البريجننت lady بيكون عندها hypertension قبل ما تبدأ الحمل وقبل الأسبوع 20 من الحمل. يعني hypertension diagnosed before 20 weeks of gestation or before pregnancy with or without end organ dysfunction. So at stage 1, stage 2, or even crisis. طيب الكاتيجوري الثانية hypertension disorders بعد 20 week. gestational hypertension, preeclampsia, and eclampsia fall into this category. طيب. For the hypertension disorders after 20 week, زي ما قلنا gestational hypertension, to diagnose it, you have to have a blood pressure 140/90, full stop. Without proteinuria, without end organ damage, this is just a hypertension with a blood pressure of 140/90. For the preeclampsia, it has 3 variants: the mild one, the severe one, and the HELP syndrome. The mild one, it has hypertension with a blood pressure of 140/90 with proteinuria, more than 300 milligram over 24 hours, full stop. This is a mild feature of preeclampsia. Okay, what is the severe one? The severe one, we have to escalate the severity a little bit. So the patient will be having severe hypertension, more than 160 systolic, or 110 diastolic with end organ damage. End organ damage could be anything: impaired renal function, impaired liver function, pulmonary edema, cerebral or visual symptoms. Cerebral by means of aneurysms, severe headaches. And for the last variant, which is the HELP syndrome, it is characterized by hemolysis, elevated liver enzymes, and low platelets. And don't confuse that with the IC. And the fourth disease of the pregnancy hypertension is the eclampsia. This one is diagnosed once the patient have preeclampsia, but with seizures. Is it clear up to now? This is a summary slide. You can read it later on. For the diagnosis, it is crucial and important to do prenatal screening, as well as measuring the blood pressure. Measurement of blood pressure, it has a special way of measuring. You have to measure it 2 times 4 hours apart. 2 times and 4 hours apart, and the blood pressure will be more than 140/90. As well as you have to do urine tests. 24-hour urine collection is the gold standard to detect proteinuria, which is more than 300 milligram per 24 hour, or urine dipstick more than 1 +1 protein, and urine protein creatinine ratio will be more than 0.3 milligram per deciliter. And you have to check the laboratory tests, the CBC, to look for the platelets, liver function tests, kidney function tests, and LDH levels. Actually, the LDH levels will detect the hemolysis, the HELP syndrome, and coagulation tests if HELP syndrome. We also must not forget about the fetal assessment. Any external pathology can affect. Okay, I 43% مجاوب gestational hypertension, and the majority of you answer the essential hypertension. Essential hypertension is correct. Okay, a 32 years old pregnant lady at week 12 of gestation with a history of preeclampsia in a previous pregnancy. Points about the treatment. The initial treatment for all hypertensive pregnancy disorders consists of maternal and fetal monitoring until delivery is feasible. And by the way, delivery is the only curative option for preeclampsia and eclampsia, which are both associated with increased maternal and fetal morbidity and mortality. And women who have had severe early onset preeclampsia should be offered low dose aspirin 75 milligram orally before 16th week gestation. And this decreases the risk of having preeclampsia in the subsequent pregnancies. So this is a summary slide for the treatment of all hypertension in pregnancy. Gestational hypertension, we manage it expectantly, and the delivery is recommended at 37 weeks. For preeclampsia, mild features, it should be watched closely, and delivery at term, 37 weeks. The severe features, we have to consider always magnesium sulfate, antihypertensive medications, and the delivery at the 34 weeks gestation. You can actually memorize that. As the severity goes on and on, the time of delivery will be sooner. And the treatment for HELLP syndrome and requires immediate stabilization, followed by delivery if the pregnancy is more than 34 weeks gestation. And the treatment for eclampsia, you have to manage the seizures and stabilize the patient, giving IV fluids, correct the electrolytes, and the delivery is the cure. And we have to also consider magnesium sulfate 6 grams. The normal prophylactic magnesium sulfate is about 4 grams. So in eclampsia, we give it 6 grams. So what do you think the answer here? What of the following decreases the risk of preeclampsia in the subsequent pregnancies? Antibiotics, aspirin, calcium gluconate, or valproic acid? Perfect. Aspirin is the correct answer. A 33-year-old pregnant lady at the week 39 of gestation presented with severe headache. Her blood pressure is 180 over 110. The urine analysis shows proteinuria. What of the following is the best management? Plasma exchange, delivery, magnesium sulfate, and labetalotherapy, ICU admission. Okay, that's correct. Most of you answered delivery. Screening for pregnant women for asymptomatic bacteriuria according to the Ultrasound Preventive Service Task Force, or US PSTF. At 12 weeks, or at 20 weeks, or at 26 weeks, or at the 32 weeks. He is asking about what is the optimal time to do screening for women who are having asymptomatic bacteriuria, between brackets UTI. Okay, pregnancy may increase the risk of recurrent bacteriuria and UTIs because we all know that pregnancy have high levels of progesterone, and actually progesterone causes urinostasis by urethral smooth muscle relaxation and dilation, and ultimately leading to vesicourethral reflux. And this will cause UTI. And the screening actually is recommended for all women who are pregnant, whether they are asymptomatic or not. And the screening should be in the first trimester. And by the way, in antenatal care, in the first trimester, what happens is that pregnant ladies undergo ultrasound examination, serum marks to detect aneuploidies, and infection screen. They are screening for infections like STDs and hepatitis and rubella and varicella and so on. UTI actually is one of the screening tests that has to be done with them in the first trimester. Now for the symptoms, we have asymptomatic bacteriuria. It presents when the patient does not have any signs or symptoms of UTI, but it is coupled with positive urine culture. You see, so that's why UTI screening has to be done in the first trimester. And we all know the other variants of UTI, cystitis, pyelonephritis. Cystitis is the milder form of UTI. The symptoms actually consist of urinary frequency, urgency, burning, and dysuria, and hematuria, and suprapubic pain. Pyelonephritis is much severe. It has fever, rigors, vomiting, and loin and abdominal pain. So for the investigations, urine analysis is the most useful markers and to detect nitrites and leukocytes. Nitrites تختلف عن nitrates. النيتريتس أدوية تستخدم في الكارديوفاسكولار diseases بينما النيترايتس are product from bacteria. الشيء الثاني اللي بنبحث عنه في اليورين analysis the leukocytes, the white blood cells. In normal urine, we don't have leukocytes in the normal urine. We have to do a culture midstream specimen of the urine. A positive result is confirmed with a culture of more than 100,000 organisms per milliliter. And we have to do also blood cultures for blood count, urine electrolyte, and C-reactive protein in pyrexial patients. We have to also do renal ultrasound to exclude hydronephrosis and congenital abnormalities and calculi. Now for the treatment. There is an oral antibiotics and there is IV antibiotics. The oral antibiotics are recommended in asymptomatic bacteriuria and the cystitis. The two milder forms of UTI are has to be treated orally. And for the pyelonephritis, it is actually treated by IV antibiotics. I'm going to show you now what are possible antibiotics that are used in pregnancy. We have to also consider IV fluids and antibiotics with patients having pyelonephritis. The duration of the treatment: asymptomatic bacteriuria, 3 days, cystitis, 7 days, and pyelonephritis, 10 to 14 days. We can use a simple trick for pyelonephritis duration. We combine 7 plus 3 gives us 10 days. It's actually a way of remembering medical information. For the antibiotic options for UTI, we can use penicillin, amoxicillin, cephalosporin, gentamicin, and trimethoprim, nitrofurantoin, and sulfonamides. You actually notice that there are some restrictions between those drugs. Means that some drugs are avoided in the first trimester, some drugs are preferred in the third trimester, and those stuff. But the most important 2 drugs to avoid in pregnancy are tetracyclines and ciprofloxacin, because tetracycline can cause permanent staining of the teeth and permanent problems with the skeletal development. As well as ciprofloxacin, it can cause skeletal problems. So what is the appropriate time to screen for UTI? 12, 20, 26, or 32? Okay, perfect. The correct answer is 12 weeks. Now for question 7. A 26-year-old woman, gravity 2, par 1, at 10th week gestation, comes to the physician for her initial prenatal visit. She is complaining of painful micturition since 1 week ago. Vital signs are within normal limits. Pelvic examination shows a uterus consistent in size with a 12-week gestation. Urine dipstick is positive for leukocyte, strays, and nitrite. Which of the following is contraindicated drug to treat her UTI? Ciprofloxacin, nitrofurantoin, amoxicillin, ceftriaxone. Remember, guys, the question asking about the contraindicated drug. Okay, that's correct. Ciprofloxacin is the teratogenic antibiotic that cannot be used during pregnancy. Now for question 8. What is the most common complication of sickle cell disease in pregnancy? UTI, recurrent chest infection, intrauterine growth restriction, hydrops fetalis. Now we are going to talk about the anemia during pregnancy. Now, we all know that plasma volume is actually expanded during pregnancy, although there is compensation by the body is compensating by increasing the red cell mass. So it is, you can see actually the percentage here. The plasma expansion by 50%, but the red cell mass is 20%. And that leads to dilution of the blood, dilutional anemia, which with the decreased hemoglobin and hematocrit. And a common mistake is that pregnant women are diagnosed with anemia by comparing their blood values with the normal ones. That's incorrect. The correct one is the hemoglobin level below 10.5. يعني hemoglobin level below 10.5 is diagnostic of anemia. A woman with the hemoglobin of 11, and she is pregnant, she is not anemic. She has to be less than 10.5. And also, there should not be a change in the mean corpuscular volume or the mean capsular hemoglobin concentration. And the normal pregnancy has a 2 to 3-fold increase in iron supplements. So we have to take care of that, as well as 10 to 20-fold increase in folate requirements. So what are the effects of anemia on the mother and on the fetus?
دكتور احمد صوتك بس شوي ارفع صوتك عشان الله بسمع.
تمام. الصوت كده واضح؟
ايوه تمام.
تمام. For a pregnant woman, the important complications are abortion, and it happens approximately 25% of the cases, increased risk of infection, preeclampsia, eclampsia, and preterm labor. And for the fetus, 10% of them are stillbirth, fetal death, and asphyxia and low birth weight. Clinical features of sickle cell disease, I'm sure we all know that: hemolytic anemia, it has painful crisis, hyposplenism, and increased risk of infections like UTIs, pneumonitis, pneumonia, and puerperal sepsis, and avascular necrosis of bone, and so on. So what are the complications of sickle cell disease during pregnancy? I have to stress on that point that women with sickle cell disease experience greater risk of UTIs, bacteriuria, and pulmonary infections and infarction. And it is actually the most common complication of sickle cell disease. So what is the most common complication of sickle cell disease? UTI, recurrent chest infections, so that's correct. Most of you answered correct. 52% of you answered that UTI is the most common complication during pregnancy. Now for the question 9. After 3-day history of cesarean section, a patient develops pulmonary embolism and hypotension. What is the definition, the definitive management? Heparin, alteplase, warfarin, or IVF, inferior vena cava filter. Now, cardiovascular diseases during pregnancy. Pregnancy is associated with the major alterations in circulatory physiology, which remains a major cause of maternal morbidity. Now, let's recap that in pregnancy, the systolic blood pressure drops, as well as the diastolic one. And the systemic vascular resistance also decreases. And there is increase in plasma volume, and the sympathetic nervous system will be also increased. It will increase the heart rate and stroke volume. So the mother will be having a hyperdynamic circulation. And you can expect that from the signs and symptoms. And actually, one confusing thing is that cardiac disease may mask the common symptoms and findings in pregnancy, including fatigue, shortness of breath, orthopnea, palpitations, edema, and systolic flow murmur, and third heart sound. Actually, these two, for the normal heart sound during pregnancy, it is mid-systolic. Mid-ejection systolic murmur is the normal heart sound during pregnancy. And evaluation of cardiac disease, you have to do for the history physical examination. And you have to do also ECG, chest radiograph, and an echocardiogram. And for the management of patient with known cardiac disease, before conception, in the antenatal care, women with pre-existing cardiac disease should receive preconception counseling regarding maternal and fetal risk during pregnancy. Okay, what happens during pregnancy? If the symptoms worsens, hospitalization, bed rest, diuresis, and correction of an underlying arrhythmia may be required. And sometimes surgical correction during pregnancy becomes necessary. But the ideal time to do the surgical correction is in the early second trimester, at the end of the first trimester. So we know from the question stem that he is talking about he's talking about pulmonary embolism. So we have to consider anticoagulation. There are several conditions require the initiation and maintenance of the anticoagulation during pregnancy. We have to consider 3 drugs: the unfractionated heparin, the low molecular weight heparin, and the warfarin. I'm sure we all know it, guys, but for the sake of revision, unfractionated heparin does not cross the placenta, and it is safe for the fetus. But it is associated with maternal osteoporosis, hemorrhage at the uteroplacental junction, and it can also cause heparin-induced thrombocytopenia. And this actually can lead to thrombosis and bleeding, thrombosis and bleeding together. And parenteral infusions should be stopped at least 4 hours before cesarean section. And another good point about unfractionated heparin, that it can be reversed with protamine sulfate. For the low molecular weight heparin, in comparison to unfractionated heparin, it produces more predictable anticoagulant response because of the better bioavailability, and it is less likely to cause HIT, heparin-induced thrombocytopenia. And it is easier to administer and to monitor, and it has lower risk of developing osteoporosis and bleeding complications. And low molecular weight heparin also does not cross the placenta, and it is safe for the fetus. the warfarin. Warfarin is a vitamin D antagonist. It freely crosses the placenta and it can harm the fetus markedly, as it can cause bone and cartilage abnormalities, especially during the 6th and the 12-week gestation. Warfarin must be discontinued and switched to heparin several weeks before delivery to avoid risk of fetal hemorrhage. Okay, let's walk you through this algorithm. If you have a pregnant lady suspected pulmonary embolism, you have to first start your approach by history and physical examination and perform some investigations like chest X-ray, the ECG, full blood count, and urea electrolyte and liver function tests. And based on that, you are going to commence heparin or you are not. If you found symptoms and signs of DVT, you have to perform compression duplex ultrasound on the legs. If DVT is confirmed, then you have to initiate unfractionated heparin. So it is a mistake here. You have to initiate unfractionated heparin intravenously. If you did not find any signs of symptoms of DVT or the compression ultrasound is not conclusive, then you have to consider chest X-ray. And based on that, if you find the if you find the chest X-ray is abnormal, then you are going to confirm it by CT, pulmonary angiography. And if it is pulmonary embolism confirmed, then you have to commence the heparin. If otherwise, the chest X-ray is normal, so you can perform ventilation perfusion scan. If the pulmonary embolism is confirmed, then you have to initiate the heparin therapy. And if it is not, after all, you have to reconsider your diagnosis. You have to reconsider your investigations and consider alternative diagnosis. So for the liver diseases in pregnancy, we have to consider 3 major diseases. The intrahepatic cholestasis of pregnancy, and this actually presents in the 2nd or 3rd trimester with pruritus and jaundice, but women are otherwise well. The etiology behind that is actually unknown. But suddenly, the patient presents with pruritus and jaundice. And the treatment, the first-line medication, is ursodeoxycholic acid orally, and the delivery should be at 36 to 37 weeks gestation or at the time of diagnosis, if diagnosed at term. The other disease is the acute fatty liver of pregnancy, and also it presents in the 3rd trimester with liver dysfunction as well as kidney dysfunction. The manifestations are jaundice, coagulopathy, bleeding, abdominal pain, nausea and vomiting, elevated AST, ALT, as well as the renal function tests. And the treatment should be immediate delivery, and C-section should be performed if prompt vaginal delivery are not possible. No joke. Immediate delivery. The HELP syndrome, as we know, it presents in the 3rd trimester with hemolysis, elevated liver function tests, and low platelets. Possibly the patient could present with pruritus, of course, preeclampsia, hypertension, proteinuria, and abdominal pain. The treatment is stabilization by IV fluids, blood transfusions, antihypertensive agents like labetalol and hydralazine, magnesium sulfate, and delivery if more than 34 weeks gestation. Have you figured the answer? What is the definitive management of this patient who's recently had cesarean section and have pulmonary embolism? Yes, perfect. The correct answer is 70% of you answered heparin, which is the correct answer. Now for the last topic. Mother delivered recently and presented with yellow milk. And come for you for counseling. What is the yellow milk? The yellow color indicates. It indicates more protein. It indicates more carbohydrate and liquid. It must be sucked because it's harmful, or it contains more salts. We are going to talk about the breastfeeding and benefits of breastfeeding, as well as to make it clear for you what is the difference between colostrum and breast milk. Benefits of breastfeeding for the newborns and for the mothers. For the newborns, it is an excellent source of nutrition. It contains more protein, rich in minerals, and water and fat and lactose, which is actually required for newborns. Actually, one side note that newborns are in need for breast milk after delivery immediately, as the breast milk also contains IgA antibodies, which is very beneficial. It protects against bacterial meningitis, bacteremia, diarrhea, respiratory tract infection, and even necrotizing enterocolitis and urinary tract infections. For the mothers, it supports bonding between the mother and the infant. It enhances oxytocin release during breastfeeding, and also it increases the uterine contraction, and in return decreasing postpartum hemorrhage. Now, what is the difference between colostrum and milk? Colostrum means first milk. بالعربي يسمى اللبن مش اللبن اللبن. And breast milk, what comes after colostrum? Colostrum actually is the product of a 9 months pregnancy. The mammary glands are forming the colostrum during those 9 months to give it for the baby for the first time. That's why it is yellow. We will know why it is yellow now. The colostrum contains 14 to 15% protein. In the breast milk, after that, contains only 4%. The colostrum, it is rich in solid, not fat. It is rich in immunoglobulins, and is actually rich in vitamin B, vitamin D, and A and E, which is required for newborns. And the protein level actually what gives the colostrum its unique color. It is yellow, in contrast to the normal breast milk. Okay, what is the yellow color indicates in that mother who is recently delivered her baby? Okay, perfect. Most of you answered the correct answer, which is the yellow color. It is indicative of more protein. That's the end of my presentation today. أشكركم كلكم لاستماعكم ويا رب يوفقكم ويكرمكم ويجعلكم قرة أعين لمن تحبون ونلقاكم على خير وشكرا.